Great. All right. Sorry, I think time was up and I had a call to it dropped. Yeah, so apart from the ECG, of course, you need to do a chest ray because we are looking something cardiac, and it's good to do an echo because the echo will tell you the cause of the arrhythmia you are dealing with. As we said, we mentioned a lot of causes: ischemic heart disease, hypertensive heart disease, valvular heart disease. Once you do the echo will tell you if there's a structural abnormality. Then, of course, a thyroid function test would help you if there's a functional abnormality. Electrolytes will tell you there's a functional abnormality because sometimes once your electrolytes go too high or goes too low, it affects the way your heart would beat. So it will tell you. So those ones, your echo won't tell you because they are chemicals and hormones. Okay, when you're talking about thyroid function test, it won't tell you. So those ones are to pick up functional abnormalities. But if you want a structural abnormality, you do what? An echo in addition to your ECG. Okay. So always think about it. Arrhythmias, you are doing ECG, you are doing echo, and then you are asking for electrolytes, and then possibly a thyroid function test. Okay. The management is you try as much as possible to manage the underlying cause. So if the patient's arrhythmia is because the patient has a hypertensive heart disease, you'd have to make sure that you are managing the hypertension and then you are giving medication for the heart disease, which we've talked about. If hypertensive heart disease is what hypertension. Usually when you hear hypertensive heart disease, the patient has heart failure secondary to hypertension. So we've talked about hypertension and we've talked about heart failure. So you make sure you are managing the hypertension and you are managing the heart failure as well. Okay. Then you go ahead and then you manage the arrhythmia. Okay. So there are so many kind of management that you can use. Okay. So you can decide to go with your drugs, which will see the groups of drugs you can give shortly. Okay. But sometimes, depending on how bad the arrhythmia is, you will need to do some form of surgery or you need to put in some structure into the heart. So assuming your SA node, you've had a very bad myocardial infarction, your SA node is all infected and all that, and it's not working anymore. And now your AV node has taken over. As I said, your pulse rate will be low. So to get it back, we go and then we put an artificial pacemaker into your heart. Okay. So the artificial pacemaker would now take control of the way your heart beats. We'll set a certain rate for the pacemaker. And at that rate, it would be beating and it will generate impulses, gets to the AV node, and then it will let your ventricles contract. So that's a pacemaker. So we use that to manage patients whose heart rates are basically slow. A patient who has a heart block, you want to put in a pacemaker so that the pacemaker would take control of the way the heart beats. Okay. Sometimes you can do what we call a catheter ablation. So using this laser and all that, we can insert a catheter slowly, gets into your heart, and then we'll try and then we burn some abnormal, especially if your heart is firing too much because you have some form of abnormal electrical pathway or your heart is firing irregularly. There's a disease called Brugada syndrome. Heart is firing irregularly. There's an abnormal electrical pathway. So we use catheter ablation, and then using this catheter ablation, we can get rid of what the impulses going through the abnormal pathway. Okay. And then we have cardioversion as well. Okay, cardioversion means that we'll put some sort of device into your heart which would synchronize the way your heart beats. Okay, so basically when your pulse is dropping or you are going into a certain state where the pulse is beating too fast, but then at the same time it's irregular, the cardioversion just what? It comes in to help, it shocks you, and then it brings your pulse back to normal. Okay, so that's cardioversion. So we have cardioversion that they can do externally. If you are in the emergency room, they would put some device there and then it will shock you. Okay. And then there's also a defibrillator, which we can use to shock you to get your pulse to normal. The difference here is that usually with cardioversion, you need a smaller amount of energy as compared to a defibrillator. And one other difference is that with defibrillator, you can just shock the patient at any time. But with cardioversion, your shocking has to be synchronized to the patient's heart rate. So that point where the heart is contracting, that is when you need to shock. So cardioversion, you are not just shocking, but you are just shocking, you are shocking in synchrony. But to defibrillation, you are just shocking the patient at any time. Okay. So that is the difference. So you can use a cardioverter or a defibrillator. Okay, so they have something called ICD, Implantable Cardioverter Defibrillator. You put it in the patient, and then you can sometimes defibrillate when you have okay, as the name suggests, or it can cause a cardioversion as well. Or it can cause a cardioversion as well. Can you hear me?
Yes, we lost you a bit, but it's better now.
All right, okay, great. Yeah, so the management, you can do a cardioversion. Just try and read around cardioversion. Read just after the lecture, just check difference between cardioversion and defibrillation. It will be easier for you. You can do a catheter ablation. You can put in a pacemaker, or you can give medications. Okay. And giving the medications, there are classes of medications that you can give. Okay. You have class 1 to class 4. And how they work, when you go down to slide 18, you see how it works. So for the heart to contract, as I said, we need the SA node to fire. Before the SA node fires, you need your sodium potassium pump to be working. Essential. You need some sodium to go into the nerve so that it would increase the positivity there, which we call depolarization. Then from there, it has to cross a certain threshold. Then the nerve would generate impulses. That's the same thing that happens in the heart. So the medications we give them to target the various points of the action potential. Okay, so we'll give it to you. We know that for the SA node to fire, you need sodium to get in at a certain stage. Okay. And then also you need potassium to get out at a certain stage. Okay. And then sometimes your heart's beating fast, you can give a beta blocker. So what we do is we'll give you a medication that will block the channel of the sodium. So the sodium cannot get in. And once the sodium cannot get in, then basically it means the SA node wouldn't be able to generate enough impulses. So the heart rate would slow down. So if you are dealing with somebody whose heart rate is very, very fast, you can give the person form of a sodium channel blocker. Okay. So what it does is that it goes and it blocks the sodium channel. So you don't have enough sodium going into the SA node at that point. Hence, you are unable to reach your action potential to even generate that kind of enough electrical impulse to cause the heart to fire for too long. Okay. So that sodium channel blockers are class 1 medication. Then you have your class 2 medications, which are basically beta blockers. Okay. So you don't want the heart to beat too fast if you are dealing with a tachyarrhythmia. So you give a beta blocker. Okay. Then we have a class 3 medication, which was the potassium channel blocker. We said that for your action potential to work, potassium has to come out from the nerve or the SA node. So when you block the potassium channels, potassium is unable to come out. So you don't reach an action potential. Hence, rate is controlled. The heart doesn't just fire anyhow. Then you have a calcium channel blocker. As you all know, you need calcium to go into the muscle to help the muscle contract. So if you block the calcium channels in the muscle, then it means you're going to have less, the muscle won't be able to contract that much, or it won't be able to fire as you expect it to be. Okay, so you realize that this antidysrhythmic drugs or antiarrhythmic drugs, as we call them, basically act to slow the heart down. Okay, so usually we use those ones to manage patients who have a fast and irregular heartbeat, and then we use the pacemakers, catheter ablation, cardioversion, defibrillation to manage patients who have and then how do you call it? You usually would reserve the pacemakers for those who have a slow heartbeat, because you'd want to put something else in their heart so that it can actually take over the heart rate. Okay, and then you use the cardioversion and then the defibrillation for those who have an irregular heartbeat, because you want to shock and then bring the heartbeat to a regular point. Okay, so it shouldn't be so difficult. So when the heart is slow, if we do cardiac arrest, you see when the heart is slow, you can give adrenaline, you can give amiodarone and all that. Okay. When the heart is fast, you give medication that would slow it down, like beta blockers or sodium channel blockers or potassium channel blockers. Okay. That doesn't make sense.
Yes, sir.
Yeah, so you just have to try and have this mountain diagram of 18 in your mind, where there's a point where sodium is getting into the cell. Because this one, we did it in physiology, so I hope you remember. So sodium entry into the cell. So it's basically a mountain, and then from the extreme left, you have 4, 1, 2, 3, and then it comes back to 4 again. Okay. Or you can say 4, 0, 1, 2, 3, and then it comes back to 4. Or it's like, whilst you are drawing the vertical line, that's a 0. Then at that point where you start drawing the horizontal line is 1. The middle of that is 2. When it comes down, 3. And then when it totally gets down, 4. And then you just know that at that point 0, you have sodium influx. At that point 2, you have calcium influx. At that point 3, you have potassium influx. Okay, and then at that point 4, you have your beta blockers. So you just try and have that picture in mind. Okay, but your own is to try and then make the diagnosis. And once you make the diagnosis of a slow heart rate or an irregular heart rate, you would quickly refer and know what treatment you are giving. You put the patient on and then you refer the patient. Okay. So I know this part of cardio is very technical. A lot of people don't like it. It's because of the technical nature. Even most of us doctors don't like this part, but it's all about the physiology. So I'll let you read over. And Nick, please try and schedule another lecture. Okay. Let's try and do 2 lectures before Saturday.
That's fine.
Okay. Yes, let's try and do 2. In fact, no, before Sunday, sorry. So our next lecture is on Sunday. So let's try and do 2 lectures in between before Sunday. And then the next one, I hope by then you would have read through this. So we'll go through this again briefly before we start atrial fibrillation proper. Okay. Because atrial fibrillation is a tachyarrhythmia, but we have to talk about it proper because that's like the commonest chronic arrhythmia you find. So we'll talk about atrial fibrillation.
That's right.
So you can just read through, put your questions down, and then the next lecture day you agree on, we'll just discuss the questions, go over it again, and then start atrial fibrillation. Okay.
All right, Doc.
Yeah.
All right. Okay. Thanks for your time. So
thank you very much for making time.
We'll meet within a week.
Doc.
Yes.
Does it
Yeah.
mean we are
Yeah.
not meeting tomorrow? Does it mean we are not meeting
No,
tomorrow?
no class tomorrow.
Doc,
No
I
class
wanted
tomorrow.
to find out. I wanted to
Come on, I say,
ask
why we-
how
we-
long
Yes.
how long does
We are
it help
responding.
the patient, the catheter ablation and then the pacemakers?
How long?
Evans,
Yes.
please
How
mute your
long does it
microphone.
help the patient?
Oh no, sometimes the
How-
catheter ablation becomes a permanent procedure. So if you have somebody who has an abnormal electrical pathway, maybe congenital from childbirth, okay, you have a patient who has that, and you do a catheter ablation for the patient. You sorted the patient out. You are not going to have a new one developing. The pacemaker has a lifespan. Okay, once you put in a pacemaker, you can't take it out. You can only change the pacemaker when the
So your line is stuttering. We can hardly hear you.
Do you get it?
So your line was quite stuttering somewhere within, so we
Hello?
lost you. Hello, sir.
Yes,
Yes, there was some
okay.
stuttering in your
Yes,
line.
I can hear you, please.
Yeah.
Okay.
Okay, that's all right, doctor.
Today the I don't enjoy that thing at all.
Hello.
Hello, Doc.
Doc,
Hello.
I'm here.
Yeah.
Hello.
Apparently I can hear you. Apparently it was muted. Sorry. Can you hear me now, please?
Yes, Doc, we can hear you now.
Sorry. Yeah, so I was saying that once you do a catheter ablation for the patient, you've sorted the patient out. Okay, it's more of a permanent procedure. When you put a pacemaker has a lifespan. So usually after about 5 to 10 or 5 to 15 years, you would have to go in and then you change the pacemaker. Hello?
Yes, Doc.
Yeah,
Go
no.
ahead.
Yes, did you get that, please?
Yes, Doc.
Yes,
Yes,
please.
please.
All right, okay.
Thank you.
I'm sorry, then you all come. The network is very terrible. My power is out. My
Okay.
Wi-Fi is not working. So that's the reason why.
Okay. That's fine, Doc.
Yeah. Okay, any other question? Any other question, or we can adjourn the class and then we meet during the week.
Yes, Doc. I think we
All
can
right,
call it
great.
a night.
All right, okay.
Yes, thank you.
You're welcome. Sorry about the terrible network there.
That's fine.
All of us, we have flight club.
All right, okay.
All right, Doc.
Okay, sure. Okay.
Thank you very much for making time.
You're welcome. You're welcome. All right. Good night.
Good night, Doc.